Well, here you have failed both the BTK inhibitors as well as the BCL-2 inhibitor. And for these patients, you have to take particular attention to how they fail. For example, many patients may fail inhibition with BTK inhibitors by mutations in the BTK itself. So genetic sequencing can identify whether there are mutations in the gene encoding BTK. And it's also important to note what type of mutations there are. The most commonly associated mutation with resistance to Ibrutinib has been mutation at 481, converting a cysteine to a serine. And that mutation precludes the Ibrutinib from forming a covalent bond with BTK, and therefore it can't take it out of commission until you make more BTK. And that shortens the activity level of BTK inhibitors for treatment. However, if they have this mutation, there may be other types of inhibitors of BTK, namely ones that do not require making a covalent bond, such as Ibrutinib, that is being investigated, as well as now the new category of drugs which are called BTK degraders, which may actually tend to push for the targeted destruction of BTK inside the cell. These may be able to circumvent then the mutation in BTK that made for one BTK inhibitor less effective. Now, similar things may be said about the drug venetoclax, and I think what we have is mutations not only in BCL2 but other factors. We also have to understand what governs the persistence of disease, either upon treatment with venetoclax or treatment with BTK inhibitors, or the combination. And how do we address those? There are factors still that we're not hitting in terms of pathways that we're not hitting that we could hit and disrupt in order to increase the efficacy of BTK inhibitors as well as BCL2 inhibitors. And perhaps with the ability to inhibit some of these other survival pathways for the leukemia cells, we'll maybe be able to mitigate the development or risk of development of resistance altogether.